Hello, everyone, and welcome to the third annual Best of Breast, our first virtual meeting. Hopefully next year we'll all be live together in West Palm Beach, Florida. This case that we'll be discussing next will be case number 4, a HER2 positive case. I'd like to start by introducing myself and everyone on the panel. My name is Reshma Mahtani. I'm a breast medical oncologist at the University of Miami Sylvester Cancer Center, where I'm a co-leader of our breast cancer program. It's my pleasure this morning to be joined by my colleagues, and I'll let them introduce themselves. We can start with you, Erica.
Hi, I'm Dr. Erica Hamilton. I'm a medical oncologist, and I lead the breast and GYN program at Sarah Cannon Research Institute in Nashville, Tennessee.
Penny.
Hi, I'm Dr. Penny Anderson. I work at Fox Chase Cancer Center. I'm a radiation oncologist specializing in breast, and I lead our breast and GYN programs at Fox Chase.
Thank you. Sunil?
I'm Sunil Badwe, professor in pathology at Indiana University, and I'm a breast pathologist, as well as I represent the pathology community at ECOG Breast Committee.
Great. Thank you. I'm so pleased to be with all of you today. Okay, so let's jump right in and start with the case. This is a 59-year-old woman who presents with a palpable left breast mass, 2.5 centimeters, and the biopsy is positive for invasive ductal carcinoma, grade 3, ER negative, PR negative, HER2 is 3+ by IHC. One lymph node is positive on ultrasound-guided biopsy, and other axillary lymph nodes appear normal. Her past medical history is significant for hypertension and hyperlipidemia, well controlled, and anxiety and obesity. She has a maternal aunt with ovarian cancer, but no other family history of cancer. So as we start the discussion, I'll turn to you, Dr. Badwe, to ask you to comment on the pathology.
So what we are seeing here on the left side of the screen is a core biopsy of the tumor. What you see in the pink areas are the dense desmoplastic reaction to the tumor, which is the blue areas. And as is quite obvious that this tumor does not form glandular structures. It's a fairly solid infiltrative mass that infiltrates the fibrostroma as well as the fat. As far as nuclear grade is concerned, you can't really see the nuclear atypia, but you can see that the cells are essentially composed of nuclei, and therefore they appear blue. Gland formation is minimal, and mitotic activity was quite significant. So overall, it got a 3-3-3 as per as the Nottingham scoring system, and therefore this is a grade 3 tumor. On the right-hand side of the screen, what you see is a staining for HER2 by immunohistochemistry. And what we see is more or less all cells are staining in a membranous pattern for the HER2 protein. So this would be a very classic example of a grade 3 tumor that is HER2 positive. ER, PR was also performed. Those are negative in this particular case.
Thank you. Okay, so as we start by reviewing the management, first, Erica, I'll ask you in terms of your approach to this case, talk us through how you're thinking about this woman who has a 2.5 centimeter HER2 positive tumor with one positive node.
Yeah, certainly we think about neoadjuvant chemotherapy for HER2 positive breast cancer if the tumor size is over 2 centimeters, or if there are positive nodes. That's where pertuzumab is approved. We certainly know we get high PCR rates with that. And in HER2 positive disease, the presence and ability to get a PCR really does predict outcome. Additionally, with the advent of the Catherine trial with adjuvant TDM1, using our chemotherapy in the neoadjuvant space before surgery is what enables us to use TDM1 for those patients that prove they're going to be high risk. So I would definitely be thinking about neoadjuvant chemotherapy for this patient to try to shrink the tumor, and also to risk stratify her so I would know if she was somebody that would benefit from TDM1 in the future as well.
Thanks. So that's a nice segue into a discussion on some of the data that you brought up. And You nicely summarized who we should be considering for preoperative systemic therapy for early stage breast cancer in terms of HER2 positive patients, those who have a tumor greater than or equal to 2 centimeters or who have node positive disease should receive neoadjuvant chemotherapy with trastuzumab and pertuzumab. So this recommendation is largely informed by some of the clinical trials that are detailed here that I'll go through in the next few slides, the pivotal studies on neoadjuvant trastuzumab and pertuzumab for early stage HER2 positive breast cancer. So the first is the NeoSphere trial, and this was a study where patients who were chemo naive, who had HER2 positive, early stage HER2 positive disease greater than 2 centimeters, were given one of 4 different arms of therapy, which included HER2-directed treatment prior to surgery, and then were given largely anthracycline-based therapy with continuation of HER2-directed therapy in the adjuvant setting. The primary endpoint of this trial was the PCR in the breast. And then also the phase 2 Trifina study, which was actually a cardiac safety trial with the primary endpoint being cardiac safety of a dual HER2 targeted therapy plus or minus an anthracycline. This trial was unique in that it did include a non-anthracycline arm, which is shown here, docetaxel carboplatin for 6 cycles in combination with trastuzumab and pertuzumab. Here you see the outcomes, patients with PCR in the 4 arms of the open label phase 2 study of the Trifina, or rather the NeoSphere trial. Again, patients received 4 cycles of randomized neoadjuvant therapy. And in the intent to treat population, you see the highest PCR rate in the pertuzumab, trastuzumab, docetaxel arm as compared to the trastuzumab docetaxel arm. Interestingly, there were almost 17% of patients who were able to achieve a PCR with a non-chemotherapy backbone at all. And that's really interesting and could potentially inform future studies which look to identify who are these patients that could be spared chemotherapy entirely. Looking at the PCR rates as expected, you see higher rates in ER negative, PR negative patients. This slide just summarizes the recommended neoadjuvant adjuvant treatment regimens with the preferred regimens I'll focus on, again, being anthracycline, largely anthracycline, and also non-anthracycline regimens. And I think we're moving away from anthracycline-based therapy quite a bit in HER2 positive disease based on some of the other studies that have shown that perhaps we can do as well without the use of anthracycline-based therapy. If there is no residual disease after neoadjuvant therapy, we are recommending, or these are the NCCN guidelines, are recommending completion of up to 1 year of HER2 targeted therapy with trastuzumab plus or minus pertuzumab. And if residual disease is noted, the Catherine data, which Dr. Hamilton alluded to with trastuzumab and tansine, would be considered and really strongly recommended at this point. So here we are reminded of the toxicities of pertuzumab, specifically pertuzumab-induced diarrhea. Most of these events occur during cycle 1, and treatment delays or discontinuation is generally not necessary. Some patients have a harder time with this than others, and I would say that sometimes it's a little tough to understand whether or not they're having the diarrhea from the chemotherapy as opposed to the pertuzumab-based therapy. But when the chemo part of the regimen is stopped, it becomes quite apparent which agent was the offending agent. Of course, we need to involve our other members of the healthcare team, including advanced practitioners, and be very aware of the need to ask patients about this side effect. Of course, we also have to be aware of the considerations for cardiac dysfunction during adjuvant trastuzumab, pertuzumab therapy, understanding that both HER2 targeted therapy as well as anthracyclines can result in decreased LVF and CHF, but no evidence of cumulative cardiac toxicity with the combination. And you see the recommendations for baseline assessment of LVEF and monitoring every 12 weeks illustrated here on this slide. And just very quickly, I'll just remind everyone about the potential for infusion reaction as well. This doesn't happen commonly, but there is the need to observe patients for 60 minutes following the first infusion and 30 minutes on all subsequent infusions. And there are recommendations for slowing or interrupting the infusion after appropriate medical therapy. So let's get back to our case. This patient and her team decide on neoadjuvant chemotherapy, and she completes 6 cycles of treatment with TCHP with a partial response on exam. She has a lumpectomy and sentinel lymph node biopsy, and on final surgical pathology, she has 5 millimeters of residual disease and 2 negative sentinel nodes. So these are some of the questions that I'll be now posing to my colleagues. Erica, I'll start with you to tackle the first question, and then we'll move to Penny to go through the radiation data.
Yeah, absolutely. You know, this is a patient that luckily did clear her nodes, which is very important, but did have residual disease in the breast. And so these are the type of patients that were allowed in the Catherine trial. You know, that percentage of population, their disease-free survival was really about 77% without TDM1, and that increased substantially. So I would talk to this patient about TDM1. You can see the Catherine study here. Again, patients were allowed with T1 to T4, node 0 up to node 3 disease that had HER2 positive breast cancers that received neoadjuvant HER2 directed therapy and had residual tumor in either the breast or the lymph nodes. And they were randomized either to finishing their year of trastuzumab or switching and continuing TDM1 instead as a new regimen. So this is where we can see there is a higher risk subset of non-PCR patients. You can see overall here on the left that the trastuzumab alone patients had a 3-year disease-free survival of 77%. And if you recall some of the other studies we've seen recently, this is much lower than we've seen in other studies for disease-free survival. And I think that's because Catherine really well picked a high-risk population. Patients that don't have a pathologic complete response, that's not how the typical HER2 patient behaves. And so we were really able to select a high-risk population that may benefit from this. You see an 11% improvement in 3-year disease-free survival up to 88%. So clearly clinically meaningful here. We also see CNS recurrence that we'll probably talk about a little bit later, being about 4% in trastuzumab arm, 5%, hard to say whether that's really different in the TDM1 arm, but certainly our therapies are very effective from the neck down, but the brain remains a sanctuary.
So Erica, given this information about central nervous system recurrences not really being different in the 2 arms, and actually, you know, there's a slightly higher number, likely not statistically significant here, but really maybe due to this concept of competing risk. You have a drug that does really well with systemic control, and then you have CNS metastases. How are you incorporating some of the other agents, like, for example, neratinib post TDM1? Is it something that you're considering?
Yeah, gosh, that's $1 million question. You know, neratinib seems to have had benefit in the adjuvant space for those patients that had hormonally driven breast cancer in addition to being HER2 positive. And so we normally don't really consider that, or at least I don't in my practice, for hormone receptor negative patients. I think it's certainly worth a conversation with patients that are hormone receptor positive and have residual disease, certainly. You know, the problem is that our Catherine trial, you know, the neratinib data was before we had Catherine. So it's really hard to say whether we're still going to get a benefit of neratinib coming after TDM1, which improved things so much. So I've discussed it with a few patients, but I can't say that it's common in my practice that patients do go on to get neratinib. The majority of them decline.
Yeah, I think we saw some really interesting data this year, which was subset analyses of the Extenet data that Frankie Holmes had presented, looking at these really high-risk patients that had residual disease, ER positive, and it started neratinib within a year of completing adjuvant trastuzumab, seeing a benefit that was much more substantial, but definitely a discussion given the balance of toxicity and benefit. Penny, I'll turn it over to you to take us through some of the radiation considerations in this case.
Thank you. So for this patient, the standard of care after lumpectomy is whole breast radiation therapy to the left breast. And the role of radiating the regional lymph nodes is based on the risk of her local regional recurrence. And as we all know, it's well established that post-operative radiation to pathologically positive lymph nodes after surgery without prior neoadjuvant chemotherapy is indicated in many lymph node positive patients. But with the increasing use of neoadjuvant therapy prior to surgery, the role of nodal radiation after neoadjuvant therapy is a question that still remains unresolved. So next slide. Thanks. So what are the indications for radiation therapy for patients who receive neoadjuvant therapy? We tend to treat patients that have any degree of residual macroscopic nodal disease after neoadjuvant chemotherapy with post-mastectomy radiation. And that's based on retrospective evidence that has suggested a higher rate of recurrence in these patients. We also offer post-mastectomy radiation to patients with residual breast disease, although the threshold to admit treatment in these patients is lower than for patients with residual nodal disease. But in the absence of prospective data to guide our approach to patients with a complete response to adjuvant treatment, we treat patients who present stage 3 disease with post-mastectomy radiation regardless of their response. And for patients who present with kind of intermediate, stage 2 disease, we evaluate their pretreatment risk factors and also the patient's response to their neoadjuvant therapy with a lower threshold to admit treatment for these patients who have a complete response. So the retrospective data for patients with the stage 3 disease, like I mentioned, it suggests that postoperative radiation can actually improve local control. And it's interesting because it's even for patients who have a pathologic complete response after the neoadjuvant chemo. And a retrospective study that included over 670 patients were treated with neoadjuvant chemo followed by mastectomy. It was noted that the post-mastectomy radiation was actually associated with a significantly lower rate of local regional recurrence at 10 years and also a lower risk of death from breast cancer. And what's really interesting is that among 46 of the patients who actually presented with locally advanced disease and achieved a pathologic CR after the neoadjuvant chemo, post-mastectomy radiation was still associated with a reduced long-term risk of local regional recurrence compared to those patients who did not receive any radiation. So in contrast, there's data, retrospective data, that suggests that there are certain low-risk patients who actually can achieve a pathologic CR with their neoadjuvant chemo, and they actually have low rates of local regional recurrence following mastectomy without even using radiation. So a retrospective study of a large number of patients, 3,000 patients that were treated with mastectomy, with or without post-mastectomy radiation, found that the radiation after mastectomy was associated with just a mild or modest reduction in their local recurrence rate compared to patients who didn't receive any radiation. And they found in this study that there were predictors of recurrence, and those included patients who had clinically lymph node involvement prior to any neoadjuvant chemo, residual cancer in the breast or lymph nodes after their chemo at the time of surgery, or patients who initially presented with large tumors, defined as greater than 5 centimeters. But patients that lacked these features were really considered low risk for local regional recurrence. So the results that I just mentioned are really retrospective analysis of larger prospective trials that evaluated different types of chemotherapy, and also the use of radiation was really at the discretion of the treating radiation oncologist for those studies. So therefore, what we really need is really high quality evidence to support and establish recommendations for radiation for patients like ours today who receive neoadjuvant therapy. And there are currently several ongoing prospective trials to actually look at this question and evaluate, is there a benefit to radiate the lymph nodes in these patients who receive neoadjuvant chemo? So the study that most people are familiar with is NSABP B51. It's a randomized trial evaluating patients with clinical T1 to T3 N1 breast cancer. They have to have positive pathologic positive lymph nodes either by FNA or by needle biopsy. They receive their neoadjuvant therapy, then they go on to definitive surgery. And at the time of their surgery, if they are found to be pathologically negative lymph node status, then they can proceed with the trial and be randomized to nodal radiation versus no nodal radiation. And what's great about this study is it includes both types of surgery. It allows definitive whole breast breast conservation versus mastectomy. So what's nice is when the patients are randomized, if they did have breast conservation, they're randomized to radiation to the breast versus radiation to the breast and regional lymph nodes. If they had mastectomy, they're randomized to radiation to the chest wall and regional lymph nodes versus no radiation at all. So it's really an exciting trial, and we really look forward to those results to help us really delineate which patients will benefit from radiation therapy after neoadjuvant therapy if they actually convert to lymph node negative disease. So just one final note about left-sided breast cancer. So what's really important when we radiate someone with the left breast cancer is the fact that their heart is on the left side. So when we're planning the radiation, we really need to take into account the radiation dose that the heart may get when you treat someone's left breast or left chest wall, because our goal is to avoid the heart at all costs, because there is, as everyone knows, a lot of literature suggesting that radiation dose to the heart over time can lead to late cardiac toxicity. So our goal, again, is to minimize heart dose, and we have very sophisticated treatment planning systems that have developed over recent years to help calculate the radiation dose to normal organs, especially the heart, as well as the lung, in order to avoid the heart and at the same time deliver the dose that we need to adequately treat the breast, chest wall, and lymph nodes to cover the patient's tumor while minimizing dose to normal tissue structures. So the technology that you might have heard about is called deep inspiration breath hold, or DIBH. So what we do is a patient inhales and they hold their breath, and we calculate and determine if this motion or activity actually increases the distance of the heart from the radiation beam needed to treat their left-sided breast cancer. And if it's deemed that DIBH is beneficial for a particular patient, what's entailed is the patient holds their breath during the radiation beam on treatment time in order to minimize any radiation dose or exposure to the heart. And this is just a pictorial. On the left is a CT slice of free breathing, and you can see the heart, which is the central structure in the middle of the pictorial, how it's close to the breast. And on the right is a pictorial of deep inspiration breath hold. So the patient actually takes a breath in, and you can see the increased distance between the heart and the breast. And the next slide probably is a little better depiction. So again, on the left, you see the yellow, which is the actual radiation beam. And you can see when someone is in free breathing mode, there actually is a portion of the heart that actually is in the radiation beam, meaning that will get radiation dose. And to the right is someone who's in the deep inspiration breath hold technique position, where you can see the heart is actually pulled away from the breast and chest wall. Thereby, that yellow radiation beam is actually avoiding the heart entirely, thereby decreasing any potential long-term risk of cardiac toxicity. Thank you.
Thanks so much for going through that. That was really a great review of all the pertinent information that is involved in this case. One question that comes up quite a bit, especially as we're seeing more proton centers around, we have a lot of patients talking to us and asking about proton therapy. Can you give us some information about how that may or may not be used in breast cancer?
That's a great question. I mean, we do not have a proton center at our institution, but in general speaking, proton therapy is really not considered standard in a regular breast cancer case, a definitive case. There is some benefit to it. It's the physics behind it, and maybe in a recurrent setting or in the certainly experimental protocol setting, but not in a definitive treatment approach at this time.
Okay, good to know. Thank you. So let's get back to our case. And just as a reminder, this patient has gone through neoadjuvant TCHP, residual disease at the time of lumpectomy, and was treated in the adjuvant setting with Kadcyla, or trastuzumab emtansine rather, in the adjuvant setting based on the Catherine data. And now, 4 years later, she notes new onset of daily headaches and some right eye blurring, and undergoes a brain MRI, is found unfortunately to have 3 brain lesions with some surrounding edema, and systemic imaging reveals 2 liver lesions and 5 bone lesions throughout the axial skeleton. I am going to ask you, Sunil, to comment on the pathology in the next slide. Again, the importance of biopsying at the time of the first site of metastatic, or the first incidence of metastatic disease, to confirm the biomarkers we know is always very important. But just in terms of the case here, have any of you been in this situation to date where you have seen a patient that has had adjuvant TDM1 and had a recurrence? Erica, have you seen this in your practice yet?
No, I haven't. Not somebody that's had TDM1 and had recurrence. I certainly in the past have had patients that present with metastatic disease, and the first thing we find is brain mets, certainly.
Sure. Yeah. And I think it brings up an interesting scenario that we're all going to be increasingly faced with, that the biology of the disease of these patients that have gone through many of our active therapies in the early stage setting may be very different when they come to first line metastatic treatment, and may really not be well represented in any of the clinical trials to date that we have with data in that setting. So let's talk a little bit about the pathology here before we get back to the systemic treatment decision-making.
So what we have here are photomicrographs of the liver with metastatic disease. So I'll talk first on the left, about the figure on the left-hand side. Within that figure, the more pink areas are the areas of sinusoidal liver tissue, and then the bluer areas scattered in between are the areas of tumor. On the right-hand side, the same liver biopsy is shown under a higher magnification. Of course, it's a slightly different field, but what you can see again is the pinker tissue with small nuclei is the normal liver, while at the bottom of that right-hand side picture, you see the tumor, which again does not show any evidence of gland formation. The nuclei are fairly big and pleomorphic, and there is some mitotic activity. In a case like this, it would be difficult to figure out what exactly the source of the metastasis is. We would obviously need to do the stains and things, but history is clearly important. And with the history of breast cancer, this is most likely to be breast cancer. And therefore, we would run the ER HER2, and which was done. And this case continues to be showing HER2 positivity and ER HER2 negative.
So back to the case, in terms of the brain metastases, she receives SRS and is started on THP. And I made this point just a moment ago that I don't know that we really know the best strategy. She did have a 4-year disease-free interval, was already exposed to trastuzumab and pertuzumab. In my practice, I would have tried to get this patient to catnib. I don't know that I would have been successful, given that we'll be hearing about the HER2 Klein data and the approval second line and beyond. But here, for the purposes of this case that I'll point out is an engineered case, she receives THP and does well for 18 months and then progresses in the brain and in the liver. So with that, now we're talking about second line treatment, and let's talk about systemic therapy options here.
Yeah, absolutely. So this is the HER2 Climb trial. So these patients had progressed on trastuzumab, pertuzumab, and TDM1. So kind of a really so-called third line population. They did have brain MRI at baseline. What was unique about this trial is not only did it include patients with stable and treated brain mets at baseline, but it also included patients that had treated brain mets and subsequently were progressive, or patients that had untreated brain mets. A little bit different than the way this patient initially presented. She had headache, she had blurred vision, she had edema on a scan, not really that scenario. But we aren't told a whole lot about these two new lesions. So it is certainly possible for this regimen to be included for patients that have not had brain radiation. So patients received capecitabine in combination with trastuzumab, either with or without tucatinib here. Next slide. So again, this is just really showing the breakdown of how many patients did have brain metastases. It was about half, 48% of the patients on trial had brain metastases, 52% did not. And you can see a breakdown over on the right for the treated stable brain metastases, 117 patients, but active brain metastases were 60% of the patients with brain mets, and that was comprised both of treated and progressive brain mets as well as untreated brain mets. Next slide. So this is what we saw, and we really saw a win across the board, whether we're talking about progression-free survival, overall survival in all comers, or progression-free survival in patients with brain metastases. I think a really striking statistic to me happens over on this third graph of progression-free survival in patients with brain metastases. You can see, if you're looking at the 1 year or 12-month standpoint, that if patients were not receiving tucatinib, none of them are progression-free. where a quarter of them were if receiving tucatinib. So certainly a big win, not only for patients with brain mets, but really all comers patients with an improvement in PFS and overall survival. Next slide. So this is looking at progression-free survival in those patients with brain metastases and particularly CNS progression-free survival. So we see a pretty impressive hazard ratio here is 0.32%, and the statistic now changes from 0% at 12 months up to 40.2% with the addition of tucatinib. And so really this translates to a 4.2-month progression-free survival up to a 9.9 month progression-free survival. So really almost 5.5, almost half of a year improvement for our patients. Next slide. And here we go for overall survival with brain mets, very similar data. You can see improvement of 12 months overall survival from about half up to 70%. And this translated to a 6-month absolute benefit from 12 months up to a year and a half, 18 months for overall survival in patients that did come on with brain metastases. Next slide. And so here we go. This was some updated data from San Antonio this year, really looking at, okay, so all the patients are HER2 positive, but is there differential activity between patients that are either hormone receptor negative and HER2 positive or hormone receptor positive and HER2 positive? And we see there were some differences. The study certainly wasn't powered to look at these individual subgroups, but it appears that we have a very good benefit in progression-free survival, regardless of whether patients had hormone receptor positive or negative disease, with hazard ratios of 0.58 and 0.54. Next.
So, Erica, how do you reconcile these data with the data that we have with neratinib in ER positive, HER2 positive patients, where there did seem to be some differential activity there?
Yeah, that's a tough question. You know, neratinib certainly hits more than just HER2 alone. It also hits EGFR, et cetera. And so it does have a little bit different mechanism of action, certainly. You know, it's also in the early stage setting. And if we're learning anything, we're learning that the biology of metastatic disease does not always recapitulate the biology of early disease. We've certainly learned that in triple negative breast cancer with immunotherapy. And so I think it's quite possible that that accounts for some of the differences we see as well.
Mm-hmm.
And then here's overall survival according to hormone receptor status. And here you see that there's a numeric benefit for the addition of tucatinib in the hormone receptor positive subgroup. But that does not reach statistical significance. Conversely, over on the right, the overall survival for the hormone receptor negative subgroup does reach statistical significance with a hazard ratio of 0.5. And I think this may just point at how strongly the tumor is HER2 driven, you know, whether that's really the driver in the tumor. So a little bit of the side effects. I've been very reassured with this regimen. I think we're very used to using capecitabine in our breast patients, and I find the toxicity and the adverse events to be very similar here. Diarrhea is common, just as it is with capecitabine. The median time to the first episode is really about 12 days, so just shy of 2 weeks. It's relatively rare to be grade 3 at about 12%. We certainly can use dose reduction here. We can use dose interruption and antidiarrheals per protocol. They did a relatively elegant analysis really showing that the very mild worsening of diarrhea with the tucatinib arm actually had to do with exposure to capecitabine, aka the patients were on longer, and so they had some more diarrhea. So in general, if I'm going to dose reduce for diarrhea, I'm going to dose reduce capecitabine first. Hepatotoxicity, this is something that definitely can be increased by tucatinib. We see it with capecitabine, but it's clear it's a little bit higher with tucatinib. We saw elevation in liver function tests in about 8% of cases in the HER2 CLIMB study. Only about 1% needed to be discontinued. Certainly we're checking a CMP when our patients come in, and so that's something that we can easily pick up. And then obviously we don't want to be giving this drug to anyone who's pregnant.
I think the comment that you made about more commonly reducing the capecitabine is really consistent with what was seen in the trial as well. The capecitabine was the more commonly dose reduced or held agent. And I echo your comments. I think in my practice, since I've used the tucatinib regimen, I've been pretty pleased in terms of the toxicity management and not having it be an issue where patients have had to too often come off therapy. pretty consistent with what was also seen on the trial. So again, let's get back to our case. Again, reminding everybody about this case and how this patient that's an engineered case was treated: neoadjuvant TCHP, residual disease, adjuvant TDM1, 4-year disease-free interval, then is treated with THP, presumably in the second line receives the tucatinib-based regimen, and now we're here third line with progression in the liver and lungs and symptomatic with abdominal pain and persistent cough with the brain disease being stable. So we have several options, third line and beyond. And I think this is actually good for patients, right? As we struggle with how to sequence these treatments, it's a good situation that we have options for our patients. Erica, I know in this engineered case, the patient had already had tucatinib in the second line, but in the third line space, in a patient that hasn't received tucatinib, how are you approaching sequencing these therapies and making these decisions?
Yeah, this is a really great question, and I don't think that there's a wrong answer. Traditionally, I think our choices probably are capecitabine, trastuzumab, tucatinib in the third line space versus trastuzumab deruxtecan. I think in general, with good randomized data, the fact that Cape Traz tucatinib was really studied in the third line, that's probably my go-to regimen for most patients. The trastuzumab deruxtecan data, and I know you're going to be going over this, but it was a very heavily pretreated patient population with a median of 6 priors. So I do feel comfortable that if that kind of waits to fourth line, patients are still going to get a good response. Certainly, if someone has brain mets, I'm thinking of tucatinib. If someone has really extensive visceral disease where I really feel like I need to get a response, whether that's liver or et cetera, I may be thinking about trastuzumab deruxtecan there first. So I don't think it's cut and dry. I think it's a little bit of the individual situation.
I agree. And, I think also the availability of the sub-Q formulation of trastuzumab has also helped to have certain patients who are looking to really avoid being in the chemo unit, be in and out much quicker, and then have an oral regimen. But for other patients where you're worried about compliance with oral therapies and pill burden, I practice in South Florida, and a lot of my patients are on multiple therapies. They're older, so that factors in as well. I think it was really interesting to see in this trial the fact that these patients, the HER2 Climb trial, that these patients that had brain mets that were active and not requiring urgent local treatment were treated with this therapy, and local treatment was not given. Penny, as a radiation oncologist, this is done on a trial, but how do you think that this is going to land with your colleagues as this agent now gets into the treatment regimens? Do you think that a lot of radiation oncologists would feel comfortable? There's that saying, to a carpenter, everyone looks like a nail. So you go to a radiation oncologist and they want to radiate. As a medical oncologist, we want to give chemo. Sunil, I guess you want to biopsy people and look at pathology. So how do you think that would be received?
I think it'd be well received. I think one of the things about our field is they call like de-escalation, de-intensification. So over the years, radiation itself has had kind of a newer focus where we're treating breast cancer with less number of treatments, hypofractionated, shorter course, and in some cases trying to eliminate radiation altogether. So as more molecular, genetics comes into play and things like that, I strongly feel that over time, we might even see some of our ASTRO guidelines change such that maybe we would consider not radiating or omitting radiation in certain subsets of these patients. Absolutely.
Anyone in favor of doing screening brain MRIs, knowing that a proportion of these patients were completely asymptomatic and found to have brain metastases, because the trial did require a baseline brain MRI regardless of symptoms or not? As a reminder, the guidelines do not recommend screening MRIs, but seeing this information, has it changed your interest in doing a baseline brain MRI?
Yeah, it's a tough question. We traditionally haven't. Certainly in HER2 positive patients, I have a very low threshold to order a brain MRI. If they're having more nausea with a regimen or they're having dizziness or anything like that, then I'm certainly ordering it. But I think your question is spot on. I mean, you know, especially when we're having to make decisions in the third line space about what may be most appropriate next, you really wonder whether we should be ordering this more frequently, as we know, you know, so many patients with HER2 positive metastatic disease ultimately will have brain mets. It certainly can't be a bad thing to catch these earlier.
Sure, agreed. Okay. So with that, let's talk about the DESTINY-Breast01 study that led to the approval of trastuzumab deruxtecan in previously previously treated HER2 positive breast cancer. So these patients, as a reminder, had centrally confirmed HER2 positive disease and had received prior TDM1. The large majority were TDM1 resistant or refractory, with a few patients that were intolerant to TDM1 also on the trial. And after a PK and dose finding stage, the dose of 5.4 milligrams per kilogram was identified as the dose to move forward. 184 patients were enrolled at this dose, and the primary objective or endpoint was confirmed overall response rate, with secondary endpoints shown here. In terms of baseline characteristics, the median age was 55, 100% female, and you see that most of these patients had a pretty good performance status, and almost half ER positive, ER negative. You see the breakdown of IHC 3+, as well as IHC 1+, 2+. Again, this trial did include patients that were HER2 positive, so those 1+, 2+ patients were ISH positive. And I'll ask Sunil to come back to this discussion of patients that are 1+, 2+ and are actually ISH negative, or the so-called HER2 low patients, and comment on that data later. These patients had visceral disease, 91.8%, so the disease burden was high. 13% had brain metastases, but again, these were not patients with untreated brain metastases. They had to be treated and asymptomatic. Here, the prior treatments are shown: 100% prior TDM1 and trastuzumab, 66% with prior pertuzumab, and then you see the breakdown of other therapies shown here. Now, these data were originally presented after the August 2019 data cutoff, and then more recently at San Antonio, we just heard some longer follow-up. And you see here the original overall response rate of 60.9%, with an additional 9 months of follow-up is now up to 61.4%, with some of these patients around 6% achieving a complete response, which is really remarkable, a very high response rate. And you see the duration of response, the median is 20.8 months, and these responses occur rather quickly, with the time to response being 1.6 months and quite durable. You see the median progression-free survival is now up to 19.4 months. This is a waterfall plot that I think has made an indelible impression in all of our minds, because I think it's something that we haven't seen with too many other agents to date. But you see that price rate of just north of 60% in a patient population that's heavily pretreated, with median 6 lines of prior therapy. And again, the progression-free survival, which I just showed you in that summary slide a couple slides ago, is now, as of the most recent presentation at San Antonio, 19.4 months. Overall survival data, again, these data are immature, as we have 35% maturity, 119 patients censored, and only 17 patients at risk at 24 months. So of course, we're awaiting additional follow-up for more mature survival data, but at this point, median overall survival 24.6 months, and you see the time points 12 months and 18 months on the right of the slide. The toxicity of this therapy in terms of common AEs is really, in my experience, been more related to nausea, some GI toxicities that are shown here, but largely handled with the use of antiemetics, and really don't too often result in the need to take patients off of therapy. Very few grade 3 events or grade 3 toxicity. The toxicity of special interest, I'll go through in the next few slides. The first, again, being the LVEF decrease, where you see as of the June 2020 cutoff, there was one additional case of LVEF decrease grade 2, but no new treatment emergent events of cardiac failure. You see these rates are really low, but again, the point being that these patients have, I think it was put, have so-called passed the cardiac stress test. I think that's how Shani Modi had put it so well in terms of their ability to tolerate these treatments, these HER2-directed therapies in the metastatic setting. The one toxicity that, of course, we're all most concerned about is the ILD risk, which, looking at any grade across the data set, was about 13.6% when originally reported. And most concerning are the grade 5 or fatal events that have been seen since the August 2019 data cutoff. 3 new cases of ILD, as determined by an independent adjudication committee, were reported at the data cutoff. 1 grade 1 event and 1 grade 3 event were pending adjudication. We really obviously want to characterize these cases so that we can better understand how to monitor and how to treat these patients. It was interesting to note that most of these events occurred during the first 12 months. Only 1 subsequent event was seen later. This suggests that, you know, this is not a cumulative side effect, but we still have to be very mindful of this. Patients have to be questioned at each visit. Do you have shortness of breath? Do you have cough? Remember, there is a recommendation to discontinue when you get to grade 2, and that's unlike any other agent that we are used to using, where we have to stop at grade 2 with grade 1 findings. Even we're supposed to consider the use of low-dose steroids. So, Erica, in your experience as you've used this therapy, have you run into this toxicity or had cases where you've had to rule out ILD so far?
Yeah, I have been working with it quite a while in clinical trials, and so I have run into pneumonitis. Luckily, knock on wood, nothing above grade 3 pneumonitis. But you know, I completely echo what you're saying. You know, it's different than immunotherapy or other drugs, where, you know, we really don't worry much until something's grade 3. You know, we certainly don't stop the drug and never go back to it at grade 2, but it's because of the frequency of fatal events here. You know, I had one patient who had just had a scan 4 weeks before on clinical trial, and it was very subtle. She had 99% oxygen saturation on room air, walked into the clinic just fine. And in talking to her, she said, well, yeah, I mean, I'm a little bit short of breath when I carry laundry up the stairs. And I kind of thought to myself, well, so am I. And I said, you know, is that new for you? And she said, yeah, it is new. And I scanned her and she had pneumonitis just 4 weeks after not having it, which was really surprising to me. She did well. We put her on steroids and she was able to come off. But then about a month after coming off steroids, she relapsed and actually had to be admitted to the hospital at that point for pneumonitis. She'd had an excellent disease response. She'd been on for 20 cycles and she ultimately recovered. But I think it's something that we really need to educate our patients about, because you imagine that sometimes grade 1 pneumonitis is going to be seen at an urgent care clinic or a primary care office and thought, oh, it's bronchitis or it's something else, that they need to know that it's something to look for as well.
Yeah, I think you make great points, and you can't find something when you're not looking for it. So this issue of scanning and the interval around scanning is something that I've struggled with. You know, I've also been involved in the trials, and it's easy when the patient's on a trial because there's a set regimen of, you know, every 2 cycles, and then after a period of time it extends out. But then once the agent is in clinical practice and it's all up to us to decide, we start to run into issues where patients are getting tired of doing scans that frequently. So I think we have information that we still have to clarify in terms of the monitoring schedule. Thankfully, I think we have a good regimen in terms of doses of steroids and when to re-challenge and all of that. I think that's been pretty clearly outlined. Speaking of that, here it is. These are the recommended guidelines for the management of trastuzumab deruxtecan-induced interstitial lung disease. So remember, grade 1 is no symptoms, and this is something that's found incidentally on imaging, and the recommendation is to monitor and closely follow up in 2 to 7 days from the onset of symptoms, and of course, pulse oximetry, consider follow-up imaging. This is something that I think we're not used to considering, but here the important point is starting steroids early. The dose is here 0.5 milligrams per kilogram per day, followed by a gradual taper. And if worsening, then you follow the grade 2 guidelines, which I won't read to you word for word, but the take-home message here is the dose is higher, and you can re-challenge at grade 1 if there is resolution of the toxicity within a certain time frame. I believe it's 28 days at the same dose, or if it takes longer, you can dose reduce. But at grade 2, we're supposed to discontinue. And at grade 3, obviously, we're talking about hospitalization and higher doses of steroids. At every time point, I would say it's important to engage our pulmonary and ID colleagues, especially here in the era of COVID that we're all going through, and recognizing where imaging characteristics may overlap. So before we finish, it's good that we're actually running pretty much ahead of schedule, I'd say, because it gives us all some time to make some closing comments. Before we go around, I'll ask Sunil to maybe circle back to the HER2 low data that we had alluded to earlier.
Sure. I mean, ever since we had the 9831 and the B31 data, there has been some thoughts about HER2 negative patients might be responding to anti-HER2 therapies. Again, remember, in those trials, all patients were HER2 positive at local centers, but were negative at the central labs. And then, of course, we had that NSABP trial for HER2 negative or normal cases, and we really did not see any significant response. So with that kind of background, there has been a serious thoughts about whether HER2 negative patients might respond to any anti-HER2 therapies. And as we come into this new agent, we're clearly seeing that patients who are negative are responding. And one of the reasons is believed is because this antibody drug combination does not just carry one drug molecule, but carries multiple drug molecules which are released in the neighborhood of the cell. And that causes a lot of destructions of the tumor cells, not only of the cell that in which the antibody is bound to, but also the adjoining cells. So this has raised enormous questions as to what represents HER2 positivity in the clinical sense. So traditionally, of course, we need the HER2 to be 3+ or FISH positive to call something HER2 positive. But these cases seem to have definitely less than that, and yet seem to respond to our anti-HER2 therapy. So we in pathology are really struggling as to what this HER2 low category is. It's possible that this is your 2+ and 1+ cases by immunohistochemistry. We really do not know as yet as to which of these patients might be responding or might not. There's an intense effort to look at the 1+ and the 2+ positive cases and seeing if these are the positive cases that, or these are the cases that would respond to this newer anti-HER2 therapy. And if they were, then we would have another problem in terms of having almost 80% of patients who would be considered as HER2 low or HER2 positive. And that, again, is another major issue that we in the lab will have to deal with. So clearly a very important question for us in the lab, and also for the clinicians treating patients who have been traditionally HER2 negative. So we really need a lot more work to figure out whether the current assays that we use are good enough to identify these low HER2 patients. FISH definitely does not seem to be the answer. So clearly a lot of work that needs to be done.
Thank you. It's so interesting to see, even after 30 years of dealing with testing for HER2, and now we're coming into an era where there may be a whole new nomenclature, as we've usually thought of HER2 positivity being black or white, and now we're seeing this new category that stands to change how we look at this situation. Closing thoughts from Penny? Anything that you want to add from a radiation perspective?
Thank you. Well, from a radiation perspective, I know we and my colleagues, we look forward to the data really to direct us in terms of offering radiation, or not after neoadjuvant therapy. It's a new paradigm for us. Up until maybe a decade ago, our job was easy. We used to say we knew when to radiate, when to not. And then once neoadjuvant chemotherapy came aboard, it really challenged: do these patients really need treatment? Why add a modality if they don't need it? And as I outlined before, that question is still unanswered, but hopefully with B51 and other ongoing trials, we'll have an answer to that, to know if a patient does benefit from radiation. And like you were alluding to with the HER2 status, positive or negative, that also might help us define which patients need radiation or perhaps don't. So I look forward to that data.
Great, thank you for your comments. Erica, you want to close out?
Yeah, I mean, along the lines of what Penny said, I think it's a really exciting time in HER2 positive breast cancer right now. Not only do we have new agents, but it's kind of this era of refining or tailoring, kind of picking the right size treatment for the right patient. And whether we're talking about, the TRAIN study where we really don't need anthracyclines for early HER2 breast cancer, or are we talking about Catherine, about accurately being able to predict who needs more? I think it's exciting to kind of think that, some patients may do just as well with less. We certainly don't want to be over treating all of our patients as well. And then we want to be able to predict who isn't going to do well with standard therapy and may need more. So I think, multiple studies we're seeing these days get at this issue. And I think it's important not only for us, but really important for patients that want to make sure that they get the right size treatment for their cancer.
I agree, and it's so remarkable to see, even in the face of a pandemic, we've had new agents approved. We talked about many of them, but we didn't even get a chance to touch on margetuximab, which was just hot off the presses, approved last month, and also the neratinib capecitabine data with the NALA trial in the metastatic setting, expanding the indication for that agent. So it's a good problem to have, because it means that our patients have choices. And I thank you all for participating on the panel, and all of you for watching. Please make sure that you ask your questions in the chat section of the app. And thanks. I hope to see you in person next year in Florida.
Thank you.